Hi everyone, my name is Noah Towbin. In this video, I will be exploring Mycobacterium tuberculosis. Mycobacterium tuberculosis is a non-motile, rod-shaped, obligate aerobe that functions as a facultative intracellular parasite with a slow generation time. As these microbes have characteristics of both gram-positive and gram-negative bacteria, it's not officially categorized as either of these. However, these bacteria do have peptidoglycan in their cell walls. With regard to staining, Mycobacterium are acid-fast bacteria that require special staining procedures to be identified microscopically. One example of an effective staining process is the Zeal-Nielsen stain, which causes the Mycobacterium tuberculosis to appear pink against the rest of the slide. The main reason why Mycobacterium tuberculosis is a significant microbe is that it causes tuberculosis, or TB. TB is an extremely contagious infectious disease that mainly targets the lung tissue. It is generally spread between people via droplets suspended in the air. There are two main types of TB, latent and active. Latent TB means that a patient is carrying TB but has no active symptoms. Active TB, otherwise known as the TB disease, refers to the condition that actually makes you sick and can be spread to other people. The mortality rate of active TB is 45% for HIV-negative patients and nearly 100% for HIV-positive individuals when untreated, making this a serious problem, especially in developing countries. The symptoms of TB include coughing, chest pain, fatigue, fever, chills, and even death due to the destruction of lung tissue associated with an infection with this microbe. The image on this slide depicts an X-ray of severe pulmonary TB. The discovery of Mycobacterium tuberculosis. Robert Koch, the German physician and microbiologist behind the eponymous Koch's postulates, first isolated this microbe using methylene blue staining in animal serum. He then reproduced this bacterial infection in lab animals before presenting his findings at the Society of Physiology in Berlin on March 24, 1882. Some other relevant innovations to Mycobacterium tuberculosis include Perquet and Manteau's tuberculin test, Calmet and Guerin's vaccine, Waxman's streptomycin treatment, and Koch's understanding of the microbe's infectious etiology. The transmission of Mycobacterium tuberculosis. This microbe is carried on airborne droplet nuclei ranging in diameter from 1 to 5 microns. Any coughing, sneezing, shouting, or singing by a person with pulmonary or laryngeal TB can lead to the spread of infectious droplets. These particles can remain in the air for hours, but they cannot survive on surfaces. Once these microbes are inhaled and reach the alveoli, infection proceeds. Infection with Mycobacterium tuberculosis leads to certain innate immune responses. Following infection, alveolar macrophages and dendritic cells recognize mycobacterial structures. After recognizing the microbe, these cells interact with toll-like receptors and activate signaling pathways to produce pro-inflammatory cytokines. Following this, pattern recognition receptor-mediated phagocytosis leads to phagosome-lysosome fusion and acidification. Ultimately, these processes lead to cell necrosis, apoptosis, or the survival of the infected macrophages. The dendritic cells also function in the adaptive immune response to Mycobacterium tuberculosis. After the live mycobacteria are presented to naive T cells in the lymph nodes by these dendritic cells, the CD4 plus T cells are activated and move over to the lungs to work against bacterial growth there. Two additional factors worth considering in the active immune response to Mycobacterium tuberculosis are interferon gamma and tumor necrosis factor alpha. Interferon gamma, made by the activated T cells, is crucial to the activation of macrophages and other mechanisms of intracellular killing of this microbe. Tumor necrosis factor alpha, produced by macrophages, dendritic cells, and T cells, helps form the tuberculoma. The tuberculoma, or granuloma, describes a method of internal containment of Mycobacterium tuberculosis. These aggregations of immune cells and debris are used by hosts to contain the bacteria and reduce their viability. However, these granulomas can also be used by the bacteria to improve their efficiency of proliferation and transmission. There are a number of ways that physicians can diagnose an active infection with Mycobacterium tuberculosis. After checking for lymph node swelling and listening to a patient's breathing, several diagnostic tests are available to confirm a TB diagnosis. In the skin test, tuberculin is injected into the forearm. A hard, raised red bump indicates that you likely have a TB infection, with size being an indicator of significance. Blood, imaging, and sputum tests can be used to further confirm a TB diagnosis. Treatments for TB depend on whether it is a latent or active infection. For latent infections, a patient may only need to take 1 to 2 types of TB drugs at a given time. Conversely, active TB requires several drugs for at least 6 to 9 months. Some of the most common TB drugs include isoniazid, rifampin, ethambutol, and pyrazinamide. For drug-resistant TB infections, an antibiotic regimen of fluoroquinolones and injectable medications are implemented over the course of a 10 to 20-month period. These are my references. Thank you very much for your attention.